Hello everyone. I am Dr. Jignesh Patel, practicing at the Sal Hospital in Ahmedabad as an interventional cardiologist. So, as a toughest case, I am going to present the very bad-looking CTO lesion PCI through the radial route. This is really very tough for me because this case I did in my first year of the interventional cardiology practice at the Sal Hospital. So, I am presenting this today. This is the patient profile. Patient was a 66-year male patient having history of the infeasible MI around 5 years back. Now he came with the symptoms of rest angina, and echo was showing the severe LV dysfunction with the infraposterior hypokinesia. And we did an angiography which showed the double vessel disease. Circumflex was non-dominant, showing 80% lesion at the origin of OM, and dominant RCA showed 80% lesion at the proximal part, followed by the long segment CTO from mid to distal RCA up to the crux. And the distal RCA, PDA, PLV was filling by retrograde collaterals from the septals of the LED. So this was the case scenario, and I will go through the angiographic videos. So this is the left system. Left angiogram, left coronary is showing some minor disease at the proximal LED, and circumflex is non-dominant. And it shows there is some around 40-50% lesion at the proximal part of the circumflex, followed by there is some diffuse plaque before the OM, followed by the critical 80% lesion just at the origin of the OM. This is the circumflex artery, and LED showing some minor disease at the proximal part. Now coming to the right coronary angiography, here you can see that RCA has some around 80% lesion at the proximal part, followed by long segment CTO right from the mid segment just at the origin of the RE branch. Such kind of the CTO lesion are really very difficult to negotiate because when there is a CTO lesion at the origin of the RE branch, it will be really difficult to pass wire beyond that CTO segment cap, because every time you want to pass the wire in the CTO cap, it will go into the RE branch. So it will be really very difficult to negotiate such kind of the lesion. Here you can see that this case was started at around 12:40 p.m. and it took almost more than 40 minutes or 45 minutes to pierce the cap of the CTO segment. So what we did, initially I took a JR, and definitely the JR, we know that in CTO segment it will not give a much support. So the considering and taking to consider the better catheters is really very important. Here we change the guide to the Amplas guide. Here we can see that we took an Amplas which will give a better support as compared to JR. Initially we took a Fielder XT wire. We were not able to negotiate the CTO lesion with the Fielder XT wire. So I changed it to the Gaia 2 wire with the help of the microcatheter. Here we can see that there is some black dot here. That is a microcatheter, and through which we passed the Gaia 2 wire, and we were able to pierce the cap of the CTO segment. Here we can see that RV branch is here coming here, and the CTO was beginning right at the beginning of the origin of the RV branch. So with the help of the microcatheter and with the stiff wire like Gaia 2, I was able to pierce the cap of this CTO segment. And after that, gradually we advanced the wire till the distal RCA. Here we can see that we advanced the wire distally with the help of the microcatheter in the next 20 minutes. As we are using the hard wire here, we cannot manipulate the wire just like the floppy wires, because there is always a chance of the perforation in such kind of the patients. So we have to be very careful while manipulating the hard wires in the coronaries, because it may give a tremendous emergency conditions like cardiac tamponade if there is a perforation of the coronary arteries. So we took another contralateral puncture in the left radial artery. We take a angiography of the left coronaries with help of the tiger from the left radial route, and we showed that there are collaterals coming from the left coronaries which are filling the LED, which are filling the distal RCA, PDA and PLV. Here we can see that there is a collaterals, around 8 feet collaterals, and that confirm the position of the my Gaia 2 wire is in the true lumen. So this is really very important, that if it is in the false lumen, then if you pre-dilate such lesions, it will give a bad dissection, and sometimes it may cause a perforation as well. So this step is really very important, that we confirm the position of the wire is in a true lumen with help of the contralateral injection and showing that so definitely in the true lumen. So after that, we pre-dilated the lesion as the lesion was really very hard, CTO segment was really very hard. And the MI was of 5 years old. So you can imagine that how hard was the lesion. So even we were not able to pass the 1.0 balloon initially through the CTO segment. So what we did that I deeply intubated the implant catheter into the RCA. First, I inflated the 1.0 balloon in the proximal part till whatever part we were able to go into the RCA, and then we inflated the balloon. With help of the inflated balloon, I deeply intubated the implant catheter till the proximal to mid part of the RCA. So that will give a support while pushing the balloon into the RCA. So here you can see that the AR is deeply intubated into the RCA. Followed by that, I was able to pass the 1.0 balloon up to the distal RCA. Then I did a pre-dilatation with a 1.0 balloon, followed by sequential pre-dilatation with the 1.5, followed by the 2.0 millimeter balloon. Here you can see that in this right angiogram. Here you can see that this was after the pre-dilatation with the 2.0 balloon. There was a long lesion right from the beginning, from the proximal segment up to the distal RCA. So imagine, you can imagine that how hard was the lesion. And after that, and alternatively, if you cannot intubate the RCA, there is always a risk of the dissection with deep intubation of the implant. You can use a guide liner as well, and that will definitely give a support while passing the balloon in such lesions, difficult looking lesions. And after that, I took a stent. Here you can see that there are two markers, right? First from the mid to distal RCA, the stent was 2.5 millimeter by 40 millimeter. That was a Racer CC stent, 2.5 by 40 millimeter. From the mid to distal RCA, I inflated the stent from the mid to distal RCA. This is the stent mid to distal RCA. It is well inflated. And after that, we took another stent from proximal to mid RCA. That was 2.75 into 36 millimeter stent, Racer CC. And this is after the inflation of the second stent, view after the inflation of the second stent. And after that, I post-dilated with the 3.0 millimeter balloon at the high pressure at 18 atmosphere from distal to proximal RCA. And this was the final result. Here you can see that the RCA is quite nicely open right from the beginning, from the proximal to distal RCA. There is no any angiography showing there is no any dissection or any perforation or any edge dissection as well. So this was the case of the RCA CTO lesion, and this was done through the right radial artery route. And we took a contralateral injection again with the left radial route only. So we didn't use a femoral route in this particular case. So now coming to the circumflex lesion, circumflex was not that bad lesion. Here you can see that I already showed the left coronary angiography. There was a significant critical lesion at the origin of the OM. We pre-dilated, then we put a stent 2.75 millimeter into 40 millimeter stent from proximal to distal circ, and this is the final result. And this is the final result. That was after the post dilatation with the 3.0 millimeter balloon. And we did a follow-up of this patient after 6 months. We did a 2D echo after 6 months, 6 months after the PCI, and we showed that ejection fraction improved from the 25% to moderate LV dysfunction. The last when I did a follow-up of this patient, ejection fraction was around 40 to 45. So after doing a CTO lesion, there was a significant improvement in the ejection fraction as well. So what are the take-home message? So femoral route is always definitely a preferable route while doing CTO lesion, because it will give a better support and all that. Another thing is that you can even do the CTO lesion through radial route also, as we did in this particular case. And the proper selection of the guiding catheter is really very important to provide the adequate support. So without support, we will not be able to pass the wire or even a balloon after passing the wire. So the selection with a proper support guiding catheter is really very important. Particularly the implants will give a better support in such kind of the lesion, particularly in the right coronary arteries. Now coming to the second thing, that always take a contralateral injection if there is a retrograde filling by collaterals is there, because that will confirm the position of the wire in the tube lumen, and that will avoid the perforation or dissection and such things and other complications. And another important thing is always use a micro catheter. That will definitely help in passing the wire, piercing the cap at the right position, and to avoid going into the false lumen. So help of the micro catheter is really very important in such patients, And another thing, if you are not getting enough support, there's always a benefit of using a guide liner or guide plus. So this such kind of the materials are really very helpful while doing such kind of the CTO lesions. And lastly, the most important thing and the primary need is patience. Uh, Patience is really very important in such kind of the chronic lesions, because without patience, if you try for few minutes, like 5 or 10 minutes, you are not able to pass a wire, then definitely you are going to defer a patient. But here in this particular case, I was able to pierce the cap of the CTO lesion after 45 minutes. So the patience is really very important while doing the CTO angioplasties. Thanks.